Welcome class. My name is Jennifer Campbell. Before we begin lecture today, I want to share with you the VARK inventory. The VARK inventory is a questionnaire that assesses the learning styles that suggest the way a learner obtains information best. The learning styles analyzed is oral, visual, read and write, and kinesthetic. My results were evenly divided between the oral strategies and the kinesthetic strategies. Oral learners prefer information that is spoken or heard. For these learners, making statements and using questions are important. Oral learners prefer to learn from the ideas of others and from what they say about your ideas. They prefer to attend class, lecture, and tutorials. They learn by reading aloud, and these learners benefit from group discussions. Kinesthetic learners use experience and the things that are real to them, even if it's through an image. They prefer practical problems, problem-solving techniques, using a hands-on approach, learning from trial and error, and learning from experience. Today in Child Health Nursing, we're going to discuss Chapter 28, The Child with Endocrine Dysfunction. This lecture will specifically focus on diabetes mellitus. Diabetes mellitus is a chronic disorder of the metabolism characterized by hyperglycemia and insulin resistance. It is the most common metabolic disease, resulting in metabolic adjustments and physiologic change in almost all areas of the body. Approximately 215,000 children under the age of 20 are living with diabetes. Diabetes is classified according to the type of treatment needed. In this lecture today, we're going to discuss type 1 and type 2 diabetes. Type 1 diabetes. It's characterized by the destruction of the pancreatic beta cells, which produce insulin, resulting in absolute insulin deficiency. Type 1 has two forms. Immune-mediated diabetes results from an autoimmune destruction of the beta cells. And then idiopathic type 1 refers to the rare form of the disease that has no known cause. Type 1 diabetes is the most commonly seen in young children. Clinical manifestations of type 1 diabetes. Polyphagia is excessive hunger. Polyuria, excessive urination. Polydipsia, excessive thirst. They also have weight loss, enuresis and nocturia, irritability, and a shortened attention span, low frustration tolerance, dry skin, blurred vision, and poor wound healing, fatigue, flushed skin, and headaches, frequent infections. They have hyperglycemia, which is that elevated blood glucose levels, and then glucoseuria, which is glucose in the urine. Diabetic ketosis is ketones and glucose in the urine, and then also has dehydration involved. Diabetic ketoacidosis involves dehydration, electrolyte imbalance, acidosis, and Kussmaul respirations. And then type 2 diabetes usually arises because of the insulin resistance in which the body fails to use insulin properly, combined with relative insulin deficiency. People with type 2 can range from predominantly insulin resistant with relative insulin deficiency to predominantly deficient in insulin secretion with some insulin resistance. It typically occurs in those older than 45 years of age, overweight, and sedentary, with a family history of diabetes. So some characteristics of type 1 and type 2 diabetes. The age of onset, type 1 is less than 20, and type 2 is increasingly occurring in children. The type of onset for type 1 is abrupt, and for type 2, it's just a gradual onset. Type 1 affects more males than it does females, where type 2, females is more prominent than males. Type 1 is 5 to 8% of the diabetic population, where type 2 is 85 to 90%. Type 1 affects primarily whites, and type 2 is seen more in American Indians, Hispanics, and African Americans. Type 1 usually appears underweight, where type 2 usually appear overweight. Insulin is used in type 1. In type 2, most of the time they can just use oral agents or in diet to control. And diabetes can also be a great imitator of the flu, gastroenteritis, or appendicitis. Let's look at the pathophysiology. So insulin is needed to support the metabolism of carbohydrates, fats, and proteins, primarily by facilitating the entry of these substances into the cell. So the insulin is the key to the cell. With the deficiency of insulin, glucose is unable to enter the cell and its concentration in the bloodstream increases, resulting in hyperglycemia. Fluid that was in the cell shifts from intracellular to the interstitial space to the extracellular space, causing the glomerular filtration rate to dilute. When glucose concentration exceeds the renal threshold, glucose spills into the urine, resulting in frequent urination. Urinary fluid loss leads to excessive thirst. With the body being washed out from the urination and the excessive thirst, depletion of electrolytes is a concern, specifically potassium. Through this process, protein is wasted by being broken down and converted to glucose by the liver. Now the body is in starvation mode. Without the use of carbs for energy, fat and protein storage becomes depleted as the body attempts to meet the energy needs. The hunger mechanism increases, resulting in polyphagia, which contributes further to the increase in glucose levels. Ketoacidosis is the complete insulin deficiency, resulting in fat breakdown to fatty acids. Glycerol in the fat is converted by the liver to ketone bodies. Ketone bodies dissociate into water and carbon dioxide. So the respiratory system attempts to eliminate the excess carbon dioxide by increasing the depth and the rate, which is that Kussmaul's breathing. The kidneys also attempt to compensate for the increase in the pH by increasing the tubular secretions, resulting in urination. If ketoacidosis is not corrected, dehydration, electrolyte imbalance, acidosis, coma, and death are possibly a result. Long-term complications is nephropathy, retinopathy, and neuropathy. So diagnostic evaluation. Children who should be evaluated are those with symptoms of glycosuria, polyuria, and a history of weight loss or failure to gain weight despite extreme hunger and appetite. Those with transient or persistent glucosuria and those who display manifestations of metabolic acidosis with or without stupor or coma. Diagnosis occurs with any of the following. They can have an 8-hour fasting glucose level of 126 or more, a random blood glucose value of 200 or more, accompanied by the classic signs of diabetes, an oral glucose tolerance test findings of 200 or more in a 2-hour sample, and a hemoglobin A1C of 6.5 or greater. So some therapeutic management. The management of the child with type 1 diabetes consists of a multidisciplinary approach. It involves the family, the child, the endocrinologist, the diabetes nurse educators, nutritionists, exercise physiologists, and mental health professionals. Treatment is focused on replacing the insulin that the child is unable to produce. Insulin needs are affected by emotions, nutritional intake, activity, and life events such as illness or puberty. So let's begin with insulin therapy. Insulin therapy. Insulin dosage is tailored to each child based on home blood glucose monitoring. The goal of insulin therapy is maintaining near normal blood glucose values with avoiding too frequent episodes of hypoglycemia. Insulin is administered as 2 or more injections per day or as a continuous subcutaneous infusion using a portable insulin pump. Insulin preparation. Insulin is available in a rapid, short, intermediate, and long-acting preparation. Insulin is packed in the strength of 100 units per milliliter. The precise dose of insulin needed cannot be predicted. Insulin requirements do not remain constant but change continuously during growth and development. The needs vary according to the child's activity level and puberty status. Daily insulin is administered subcutaneously by twice daily injections, by multiple dose injections, or by means of an insulin infusion pump. To the right of the slides, you will find a list of different types of insulins and their action times. And then monitoring. Daily monitoring of blood glucose levels is an essential aspect of appropriate diabetes management. Self-monitoring of blood glucose is used to test their own blood glucose and adjust insulin regimen to maintain optimal blood glucose levels. Hemoglobin A1C assesses the control of diabetes, reflecting the average blood glucose over the last 2 to 3 months. Nutrition. Essentially, the nutritional needs of a child with diabetes is no different from those of a healthy child. Meals and snacks must be eaten according to the peak of the insulin action. And the total number of calories and proportions of basic nutrients must be consistent from day to day. Exercise. Exercise lowers the blood glucose levels, depending on the intensity and the duration of the activity. Regular exercise aids in the utilization of food and often results in a reduction of insulin requirements. Hypoglycemia most commonly occurs before meals and when the insulin effect is peaking. Even with good blood glucose control, a child may have frequent experiences of mild symptoms. If recognized early and promptly relieved by appropriate therapy, the child's activity should be just briefly interrupted. Glucagon is sometimes prescribed for home treatment of hypoglycemia. It's available in an emergency kit that must be mixed at the time of use and administered intramuscularly or subcutaneously. Illness management. We're going to follow the sick day plan prescribed by the doctor. The goal during the illness is to maintain normal blood glucose levels. We're going to treat the urinary ketones and maintain hydration. We're never going to admit insulin, but alter as needed. Fluids are the most important intervention to remain hydrated and flush the ketones through illness. Management of DKA. Diabetic ketoacidosis is the complete state of insulin deficiency and is a life-threatening situation. Management begins with a rapid assessment, adequate insulin to reduce the blood glucose levels, and fluid and electrolyte replacement. Patients in DKA are admitted into the intensive care unit. They will have a venous access placed for fluid and electrolyte replacement. An insulin drip will be started and they will be placed on a cardiac monitor. Labs are drawn frequently, and sometimes patients require a little bit of oxygen. Depending on the severity of the patient, other interventions may be necessary. So signs and symptoms of hypoglycemia and hyperglycemia. Hypoglycemia, shaky feeling, hunger, headache, dizzy. They may have difficulty concentrating, speaking, or focusing. They may have tremors, tachycardia, shallow respirations. Can even lead to convulsions, shock, or coma. And then hyperglycemia, they have thirst and weakness, may have some nausea and vomiting, some abdominal pain, dulled sensory, confusion, diminished reflexes, deep and rapid breathing, so that Kussmaul's breathing, and blurred vision. So nursing care management. Let's begin with hospital management. DKA requires an intensive care unit stay, as we've already said, frequent vital sign monitoring, fluid and electrolyte replacement, and an insulin drip. Once the critical period is over, the task of regulating insulin dosage to diet and activity can begin. And then child and family education. There are several organizations prepared to assist with education, such as the American Diabetes Association and the Juvenile Diabetes Research Foundation International. Medical identification, such as a medical alert bracelet with the condition and contact information for an emergency situation. The nature of the disease. It's highly beneficial for the patient if they're of age and the caregiver to have a clear understanding of the pathophysiology and the action of insulin and glucagon in relation to caloric intake and exercise. Meal planning. Nutritionists should be consulted and a part of the diabetes management to create a specific individualized plan for the newly diagnosed pediatric patient. And traveling. When traveling, make sure you plan to consult your practitioner for extra supplies. Consider what and how much is needed and what will be needed in transit and when you arrive to your destination. And then insulin. Families need to be aware of the treatment methods and the insulin prescribed, including the effective duration, onset, and peak. Insulin should be refrigerated but not frozen. Open vials are good for up to 30 days, and all diabetic supplies should be left out of the heat. The injection procedure. Insulin can be injected anywhere there's adipose tissue, so anywhere there's fat, at a 90-degree angle, and the site should be rotated to prevent scar tissue buildup. Monitoring. Nurses are going to be prepared to teach patients how to monitor their own blood glucose levels. Hygiene. Children should be advised to be cautious when wearing shoes without socks, sandals, and walking barefoot. Diabetic patients should have routine dental visits and yearly eye exams. Exercise. We want to remember that exercise lowers blood glucose levels, depending on the intensity and duration of the activity. Exercise can reduce the amount of insulin required, and before exercise, a small snack should be eaten to prevent and to reduce the severity of hypoglycemia. Record keeping. Keeping your home record is an invaluable tool for a diabetic patient. The child and caregiver are encouraged to observe for patterns of blood glucose response to events such as exercise. Self-management. Self-management is the key to close control for diabetic patients. Being able to make changes when they are needed rather than waiting on the practitioner or physician to make the changes for them is invaluable. It also gives the patient a feeling of control over their diabetes. And then child or adolescent and family support. Nurses should always keep in mind that just as the physiologic response affects the child, the parent and other family members of the child with the newly diagnosed diabetes experiences various emotional response to the crisis. So accommodate to those needs. This concludes the lecture on diabetes. Please complete the case study 81 on page 381 out of Winningham's Critical Thinking Cases in Nursing, Medical, Surgical, Pediatric, Maternity, and Psychiatric. The due date for the case study is to be completed by the next class.